If you have a family history of blood clots, or you have your own personal history of blood clots, something you must let your doctor know. So if we need extra workup before we take you to the operating room, we can do that. And or if you need to be on blood thinning medication longer than just the hospital stay or at a higher dose, we can address that before we take you to the operating room. Of course, when you give blood thinning medication, the risk that we are willing to take with that is bleeding. I have yet to take somebody back for bleeding. The idea is that if worst case scenario there is some bleeding, we can take care of the bleeding. Even if that requires a trip back to the operating room, you can take care of the bleeding. But once you develop a blood clot, the concern with the blood clot in the leg is that if part of the blood clot breaks and travels into the lungs, it happens really fast, and it can cause what we know, which we call pulmonary embolism, also known as PE, which can lead to even death. That's why we work very hard to minimize the chances of blood clot, and we are willing to take or accept the high risk of bleeding. Once again, I have yet to take anybody back to the operating room for bleeding, so it's a theoretical risk more than a practical risk. However, whenever you give blood thinning medication, the risk of bleeding does go up based on all the scientific evidence that we have. The other complications are specific to the surgery itself. So I'm going to start off with the gastric bypass, which is a combined procedure, both restrictive and malabsorptive. You can look at this picture. The new stomach is very small. We call it a gastric pouch, a small fraction of what the normal stomach was. And so anytime you put in more food than the stomach can handle, you're going to have nausea, vomiting, and abdominal pain. In the bypass, there is rerouting of the gut. We bring a part of the small bowel up and hook it up to that small gastric pouch. Anytime you hook two pieces of the gut together, we call that anastomosis. We are relying on the body's ability to heal completely, and if it does not heal completely, it can cause a leak. The leaks can happen very early, right after surgery, or it can happen as far out as 4 to 6 weeks after the operation. And some patients can present with leaks, becoming very sick, getting fevers, abdominal pain, dropping their blood pressure, and that would warrant a trip to the operating room to address the leak. Sometimes the leaks, especially the ones that are slow and get manifested weeks later, can present themselves as abdominal pain, nausea, vomiting, and we find out there's a collection in the abdomen. And then you treat it either with drains, with a stent, with antibiotics. The treatment varies depending on the timing of the leak, the way the patient is clinically, and where the leak is. The chances of the leak in gastric bypass is anywhere between 1 to 2%, and it varies from institution to institution. The other anastomosis that is performed in gastric bypass is small bowel to small bowel, which is the lower hookup in this picture. The chances of leaks in this anastomosis are lower, but it potentially is there. Then the other complications that can happen is marginal ulcers, bleeding, internal hernia. Internal hernia can happen up to 2 years after surgery. It is caused by when patients lose a lot of weight. The fat that was initially filling in the gaps and the holes has gone down, and if that gap or the hole between the gut and the mesentery opens up, it is potentially a chance for another loop of small bowel to sneak in and get obstructed. That's the rationale behind behind internal hernia. If that happens, it manifests as abdominal pain. We tell our patients, whenever you have abdominal pain after weight loss surgery, especially gastric bypass, definitely call the surgeon. There's no such thing as stomach flu after you've had your bypass or your bariatric surgery. We'd rather check you out in the operating room, do some extra testing, make sure it is not a problem associated with surgery than to assume that it is not. With the gastric bypass being a malabsorptive procedure as well, there is complications of malabsorption. We are bypassing the duodenum, the first part of the small bowel where the iron and the calcium are absorbed. So the gastric bypass patients specifically have to be on vitamins for the rest of their lives and be very regular with follow-up and getting the vitamin levels checked. On the topic of gastric bypass, it is considered the gold standard of weight loss surgery right now. It has the highest percentage excess weight loss. Excess weight loss is if your ideal body weight is 150 pounds and you're 250 pounds, so you're 100 pounds above your ideal body weight. And we compare the different surgical options with in terms of how much of that excess weight are they able to help the patient lose. So for example, with the gastric bypass, the percentage excess weight loss in an average patient is in the high 70s. With the sleeve gastrectomies, it can be in the high 60s, and in the band it's anywhere between 35 to 40%. So these are average numbers, and you can see there's a difference between the band, the bypass, and the sleeve. Now, this is not to say that an individual patient cannot drive the percentage excess weight loss much higher. So I've seen band patients who have been able to drive the percentage excess weight loss up to 90%. They're the ones that who are very regular, exercising, being very compliant with the diet, and they've done great. So once again, these numbers are average, and what the amount of effort you put in your post-op course will drive your success. With the band, it is the least invasive of the three procedures. There's no cutting and stapling involved, and hence the leak is not a complication of the band. However, it is a foreign body. It requires a part of the foreign body, which is the port, sits underneath the skin above the abdominal wall. You can't see it. In the beginning, you won't be able to feel it, but as you lose weight, you might be able to feel it years later. It requires very regular follow-up because the adjustment of the band, which requires the saline injection to the port, and the saline travels through the tubing into the band, and the more saline you put in, the more restriction you get. And for those adjustments to happen, you have to have regular follow-up with your surgeon so that they know when would be the right time for the adjustment. Putting too much fluid can cause problems, and putting too less fluid is not going to help you with your weight loss. So the right balance is important. It's key. Now, there are complications that can happen with the band long term. As I said before, it's a foreign body. If it stays in your body for many years, it can lead to slippage, erosion when the band kind of erodes through the wall of the stomach. The port, which is sitting underneath the skin above the abdominal wall, can have problems such as infection, port malpositioning, requiring another trip to the OR to reposition the port. So these are the things that can happen. They don't happen very often, but they can happen. Something to keep at the back of your mind when you're weighing the risks and benefits between the different procedures. I study all my patients getting ready for the band with esophageal manometry. Esophagus is the food pipe leading into the stomach. And manometry is a motility study. It's a muscular tube, and I study my patients pre-op because the stomach was not made to have a band around it, and some patients will react in ways that will make their life after the band uncomfortable, such as persistent nausea, vomiting, spasms of the esophagus, and I study them with the motility study before to be able to unmask that, so we know whether putting the band would be a good idea or not.